because in terms of this topic, you know, I think we could easily do a day course easily on this. We're actually doing some recording this evening as well. So this is live on the my Facebook feed. So if any of you want to kind of re-watch it, they will just be able to go back onto the Facebook page, won't they, and re-watch it if anybody wants to watch it. For those of you who are watching on Facebook, you can submit questions online, but it will be tomorrow and the end of the week when we get back to those questions. So I'm quite happy for anybody who wants to, who's watching online, to submit any questions. So I'll get cracking. I'll let Peter introduce himself. So I'll move aside and then I'll be back in about 40 minutes.
Thank you, Dominic. I'm honoured to be invited, very happy to be here. It's one of my favourite things is my working relationship with the whole team at Smile Concepts, and the things that we can do for our patients really excite me. So I'm very happy to be here tonight sharing the orthodontic perspective on those things. I'm going to tell you a little bit about myself and then introduce some of the concepts that we are trying to achieve, our objectives in working together, and then I'm going to show you a lot of cases. I'm going to try not to focus too much on a lot of orthodontic detail, but more on the principles of what we're trying to achieve and overall how we've done that. So my dentistry story goes back to 1982 when I graduated as a dentist in Bristol. I've had an interesting and varied career, but certainly did a sort of typical series of hospital jobs in oral surgery and things like oral medicine, oral pathology. I worked in general practice for a while and gained my fellowship, and then was accepted to study orthodontics for 3 years at the London Hospital, as it was called then. And then when I graduated, I decided I wanted to have my own practice, so I bought a house in Solihull and opened my doors. We lived upstairs. I have, for a period of about 6 years, done some part-time clinical teaching at the Eastman and Royal London hospitals, but really all of my working life has been essentially in this building. This is what it was like as a house in 1989, and it really doesn't look much different now on the outside, but on the inside it's completely different. There's nothing that's the same. My family and myself moved out many years ago, and the whole building now is devoted to the practice. We've recently done a refurbishment and stopped using study models for our work, so we scan all our patients and work digitally. I have a very good working relationship, very lucky to have my excellent colleague Virginia Rootkin-Gray, who's also a specialist orthodontist who has worked with me for 10 years. So. And we have a lot of adult patients, and so often there's a restorative input in their treatment. And I work with everyone at the Smile Concepts team, but in particular I've done a lot of work with Claire Burgess and Dominic, of course, and so I'd like to acknowledge the excellent things that you both do for my patients, and you'll see the evidence of that as we go along. So this I have taken from Dominic's presentation, and it's really some of the things that can be the benefit to the restorative dentist. So less tooth preparation, midline corrections, reduced gingival display, improved symmetry, golden proportions for restorations, and vertical changes in the positions of the teeth, because that can also affect the soft tissues. And I always feel the need, often because questions are, it's an anticipation of the sort of questions that I get when I speak on this subject, is about how fast teeth can move. I think there's a big pressure for orthodontics to be speedy. I think it's often marketed as being speedy, which is not my priority. My priority is quality of outcome. I'd like the treatment to be as fast as possible. But the reality is that how fast teeth can move in an individual is determined ultimately by their biology. And a short-term treatment, to me, it might just be a very simple case that doesn't need very much tooth movement, or it may be that there are only certain tooth movements happening, and that's not a problem at all. If there are going to be undercorrections to the ideal, what would be otherwise be the ideal, I don't think that's an issue, as long as it's covered by the consent process. And the thing that underpins all of it is retention. The more I move teeth, the less I seem able to make them stay. I think the reality is that we should always assume that orthodontic tooth movements are going to be inherently unstable, because why were they in the other positions to start with? So there isn't a magic appliance which will make teeth more stable. The teeth don't know what's applying the force. And as in any type of dentistry, the key to success is selecting the right case, and that depends on what your abilities are, and also what your limits are. You need to know your limits, because otherwise you can't do your duty to your patients. But there's a bit of a tension here, because if none of us ever explored the limits of what we knew, we'd never change. So when we do new things, we need to be vigilant, and also have a plan or some concept of what we're going to do if things go wrong. And of course, the consent has to be appropriate. We don't make if all our treatment plans were just ideal treatment every time in every occlusal and aesthetic sense, then we wouldn't have to do very much planning in some ways. And certainly, I think patients need to know what the alternatives are, but very often the thing that's best for the patient is a compromise that meets their needs. Retention is something I've already mentioned and emphasized, and this is an example of something which I think is the kind of thing which I think is a problem. It's a very happy patient who's had alignment. It doesn't matter what the appliance is, but it was done with aligners, but this could be the outcome of a fixed appliance treatment done with flexible nickel titanium wires. I'm not able to reduce overbites with nickel titanium wires. I find I can only do it really with treatments that involve steel wires that are more rigid. So the patient's got alignment, but they've got a deep overbite. So retention is really a problem here. And they have a very nice fixed retainer, but the trouble is the fixed retainer is receiving very heavy forces, and it's been getting stress fractures. Sorry. And the issue is the fixed retainer keeps breaking. So unless the overbite is corrected, even though it's not the patient's concern, then there is a problem with retaining it. So here, sorry, I got the pointer mixed up. Here I've done a repair for this isn't my case, but I was asked to help with the retention. But there's so little clearance here. This is, I think, bound to fail, and indeed about 6 months later it did fail, and the problem is there's no real clearance to make a repair that's going to be durable. So maybe the answer is only using removable retainers, but these are the kind of things that need to be considered in the plan, not just meeting the patient's needs, but how are we going to maintain things. So I would say it's about working smart and working safe, and I try and apply that to my own practice. Going through the list that Dominic supplied me with, I want to talk first of all about vertical movements of teeth and achieving the proportions that a restorative dentist wants for the follow-up work. And I'm going to start by speaking about David here, who has had orthodontic treatment when he was younger, but unfortunately also suffered trauma to his upper left incisor, and this tooth has been root filled and has a post crown of sorts, and it isn't simply alignment that he needs. What we want to do is, as a part of the orthodontic treatment, is reorganize the tissues that surround the teeth, and by making vertical movements of the incisors, by extruding the long right central incisor and intruding the short left central incisor, I want to achieve harmony of the gingival margins. But the other thing I want to achieve is to reduce this black triangle. My assessment is that the root is lying somewhat distally, and this triangular space is not going to be as easy to manage if the root remains distal. And so actually the orthodontic is quite simple once you've decided to do that, because it's just really about putting the brackets in the position that will achieve those movements. So here you can see the bend in the wire is going to extrude the long tooth, and it's going to intrude the shorter tooth, but also kick the root mesially. And after some progress, reposition the bracket, and it's the same thing again. The wire here is distorted to pull the right central down. It's going to intrude the left central and move the root more mesially. And it comes to a point where I've created an aesthetic issue by shortening the one crown, so I just did a little crude composite build-up. That's the sort of that's the best I can do, really. But it just keeps the aesthetics in reasonable shape while we're finishing the orthodontics. And it is important to try and detail things with wire bends, because otherwise you're relying solely on bracket positioning, and actually it's impossible to know exactly where to put a bracket to achieve a precise tooth position in a situation like this. So it's always going to end up involving some bending of wires, which is great because I love bending wires, so that's the really fun bit. And then it's simply a debond, and then David goes to see Claire, and she makes a temporary restoration for him. I have to make sure that the retainers are still fitting. That's why I've seen him. Otherwise his teeth will move during the restorative process. So there we are at the start, and here's the final restoration, a beautiful crown which is very well matched to the adjacent tooth. Has it had a little build-up as well? I think so, but in terms of space it's matched, and so we have to stabilize things, and so you'll see here the fixed retainer has been sectioned, so Claire had to section the retainer to work on the teeth, so things were held during the restorative phase by the removable retainer only, but as soon as possible after that I want to reinstate the fixed retainer, because my assumption is always the teeth are going to move, and possibly very, very quickly. So here we have an improvement in the smile, which couldn't have been achieved without a restorative input, but the restorative quality of the restorative work couldn't have been achieved without the orthodontics, and this is the kind of symbiosis that's so exciting about working jointly on these cases. So the orthodontic plan, here you can just see the narrowness of the arches. So the orthodontic plan is going to be to harmonize the gingival margins and raise them both, and also to manage the black triangle, which is going to involve a little bit of interproximal reduction and then bringing the teeth together, which will squeeze the papilla. And you'll be familiar with Tournose's work, which quantifies the relationship between the crest of the bone and the contact point. And if there's a distance of only 5 millimeters between the contact point and the crest of the bone, then you've got a virtually guaranteed to have a nice papilla. But the bigger that distance, then the less likely you are to have a satisfactory papilla. So I've started with some interproximal reduction, and then surprise, surprise, I've bonded the brackets low down so that we can intrude them. And here you can just see this is just at the beginning with flexible wires, so the teeth are going to go up. And essentially it's the same kind of sequence that you saw with the previous patient, repositioning brackets, but just to save time I've cut to the end. And really it doesn't look that great, but I'm happy because I've had feedback from Claire regarding exactly where she wants the teeth. She's happy with the widths and the heights, so I can hand her over to Claire, and here we've got 2 new crowns, and then some BioClear build-ups on the laterals and the canines. The overbite's reduced, and we've got a really near ideal or ideal tooth proportions here. There's a fixed retainer, because if there isn't a fixed retainer, I'm going to be worrying that if we're only relying on a removable retainer, I'm going to be worrying about things moving. So I want to know from Claire what the dates are for this work, and if possible, I've In Rachel's case, I was able to book her in for a new fixed retainer almost immediately after the completion of the restorative work. And Dominic's going to talk more about this subject, but I just wanted to show you some examples with Class 2 Division 2 cases. If you change the torque on the teeth, you get a change in lip dynamics. I'm not talking about vertical intrusion of the teeth. We can do individual teeth, but it's actually quite difficult to intrude whole segments, at least without using additional anchorage. But if we change the inclination of the teeth, we'll consistently get a change in lip dynamics that reduces the gumminess of the smile. And what's happening is that the lip is not retracting as... Oh, sorry. So the lip is being pulled up here as the smile occurs, whereas here the lip is sitting a bit lower. And for all of these cases, it's the same story. I haven't actually significantly intruded the teeth, but it's the change in the torque which allows a change in soft tissue dynamics. But it's very predictable. Here is another example, and Dominic's going to tell you more about the restorative management. But the story here for Emma, who we treated together a long time ago, is that her veneers, which were put on to mask her crowding, kept coming off. She came to me without any wish to have orthodontic treatment at all, but her GDP was getting quite worried about litigation because her veneers were coming off about once a month. And so I knew that to deal with this I had to reduce her overbite. She was very keen not to have an appliance that showed. I needed to use fixed appliances to do her treatment. I was worried about having to bond fixed appliances to veneers that were coming off, but the solution came by using lingual fixed appliances to reduce the overbite, and this is the first type of lingual appliance. I started using this in 2002. I stopped using it about 2005. It's quite bulky, but the point that made it so useful is it's quite a precise system, and it's got a bite plane, which is fantastic at reducing overbites. So the problem with the veneers coming off stopped as soon as we did the bond up. The change in the torque or the inclination of the teeth caused a separation of the contact points. These veneers haven't been trimmed, but they've moved to a wider arc of a circle, and that's why the contact points have separated. She's got her fixed retainers on, and she goes for her restorative work. Here's her smile at the beginning. This is her smile after the orthodontics was completed, but before the restorative work. And you can see a really significant difference in the gingival show. And here are the super restorations that Dominic made for her, and he also helped to manage the retention by making the temporaries joined. Emma's an example of a case with a deep overbite, and deep overbite is one of the most difficult things to manage in an adult patient. It's much easier to reduce overbites in a growing patient. If we can't treat the overbite, we can't satisfactorily treat the case. But there are things that we can do that happen to be rather helpful and involve restorative work that can help us with our overbites. So I'm going to just show you Sally here, whose concern is about the gap between her incisors here, but she has an overjet and fairly thin soft tissue type, quite strong nasal and chin features, so her smile lacks fullness and her lip is tending to trap behind the upper incisors. Do we want to reduce an overjet in a patient like this by retracting the upper incisors further? Well, she's got the space here for retracting the incisors because she's missing a tooth here, and she wants this space closed. But if I retract her incisors, I think I'm going to compromise her facial aesthetics and her smile fullness. An additional complication is that she has quite a low maxillary sinus here, and so my plan is to reopen space in the lower arch where teeth have been lost previously. The lower arch is obviously contracted where these teeth have tilted, and so I think it's reasonable to advance the lower incisors increase the lip support, and in the same way, a happy coincidence is that advancing lower incisors is a good way to reduce a deep overbite. So we're going to expand the lower arch. We are going to contract the upper a little bit, but it's going to be lower arch expansion that reduces the overbite and increases the lip support. I'm going to do some bone creation by moving the first premolar back into contact with what is the second molar, because that's going to create bone. And here you can see what typically happens when you open a space is that you get a sort of exuberant bone formation, which is very suitable for implant placement. So here's the start. I've used a little bite turbo to help disengage the occlusion. She's got ceramic brackets on her lower teeth, and we don't want her to bite on those. And at the end, we've got a very nice alveolar ridge. We've got the premolar in contact with the 7, and very importantly, got a fixed retainer. I put that on the day that I took the brackets off. As soon as I took the brackets off, a space started to spring open here. So you can't manage this with just removable retention. Ultimately, I see this as a temporary fixed retainer, but until the implant goes in, I don't want to take any chances. So here's her pre-treatment occlusion with the deep overbite and increased overjet, and then we have during treatment, you can see the advancement of the lower incisors, and finally, after the removal of the fixed appliances, but before the implants have been placed. By moving the premolar back, we've got much more bone, and it moved the teeth into an area where the sinus isn't opening the space where the sinus is not so low. Here are the 3 implants, and the implants are essential. Patients say to me, "Oh, do I have to have the implants?" Well, you don't have to, but it's stabilizing the orthodontic treatment. Having the fixed retainers is not enough. The whole segment will retract if those spaces aren't stabilized with something, and I think the best way to do that is with a fixed restoration, preferably an implant. So the restorative work is essential for helping to stabilize the orthodontics. But I would always want to have really secure fixed retainers, and all overlaid by nighttime removable retainers. It takes a real commitment from the patient. But what we've got is not only a correction of the malocclusion, but a subtle change in the smile, which is much more youthful, much more balanced, and a very happy patient. Following along this principle of advancing teeth to reduce overbites, I'm going to show you Chris, who was a candidate for surgery at a hospital in Derbyshire, and he came to me because he really didn't want to have jaw surgery, but his upper incisors had been protruding more and more, and it really was disfiguring him. I didn't look at him and feel that his jaw position really warranted advancement of the mandible, but his malocclusion did. So I set about a plan which didn't involve jaw surgery, because I didn't think the problem was the jaws. The problem was the tooth positions. As is often the case in these patients, they've had well-intentioned extractions as children, and they've been unlucky in how the arches have changed. And what can happen is, as the spaces close from the extractions, the overbite increases. And what's happened for Chris is his lip has got between the upper and lower incisors. He's got a very active lip. So the upper incisors have been proclined and the lower incisors retroclined. As the lower incisors retrocline, the overbite gets deeper. So if we procline incisors, we can reduce overbites. If we retrocline them, we can increase an overbite. Now, proclining incisors is not really the done thing in orthodontics often. Because there is a concern that advancing the lower incisors can result in recession. But if the roots are kept within the alveolus, then significant proclination can occur without recession. But the key is understanding the prescription of your fixed appliances and understanding your mechanics. So it has to be the right kind of proclination. I've just circled here just to show that he's actually missing 3 premolars and 1 canine. A very low angle here, almost parallel maxillary plane to the mandibular plane. And you can see on the radiograph the step in the occlusion. So the treatment's going to be non-surgical. I'm going to reopen the lower arch spaces where premolars were extracted and align the arches. I need a bite plane to disengage his occlusion, otherwise I'm not going to be able to advance the lower incisors. Here you can see the step in the arch. I've inverted my MBT prescriptions, so I've got plus 12 degrees of plus 6 degrees of torque on the lower incisors, which means the crowns are going to come forward when a rectangular wire is placed, but the root should stay back. So once we've got some overbite reduction that's occurred as the spaces start to open, then we can discard the removable appliance and begin aligning the upper. It's really astonishing how distorted the arch wires are, how how distorted they need to be to start alignment of the teeth. And then it's space closure in the upper and continuing space opening in the lower. And at the end, we've got well-aligned arches, we've got a reduced overbite, a reduced overjet, we've got nice amounts of bone here, and he's been checked by Dominic, and I've been given the go-ahead that he's got enough space to have his implants. I had planned for him to have a build-up of the premolar to mimic a canine, although he's not too keen to do that. I'm retaining before the implants with a removal retainer that's got teeth on it. I don't want those spaces to close. The cephalometric analysis, I don't want to show too many of these, but what this does show is I've proclined the lower incisors by 20 degrees and I've increased the lower face height quite significantly. And those are things we're not really supposed to do in orthodontics, but if we do it the right way and retain it, then it is successful. And I've just put this in to show there's been no recession whatsoever, even though I've advanced the lower incisors significantly. And that's because we can see that the apex of the root has stayed lingually in the bone. So here he is after his implants have been placed, and the implants are essential for stabilizing him. His overjet's still 2.5 millimeters, more than a year after his orthodontics finished. So again, we're retaining with restorations as well as fixed retainers, and over the top of that he's wearing removable retainers. And there's a significant change in his facial balance. You know, it was interesting, he was here the other day and said he was going to dancing class after his appointment, and you know, to me there is a complete change in his demeanour now that we've done the orthodontics, and I'm not surprised really, because he was really significantly disfigured by this. Karolina has had 2 courses of orthodontic treatment before she's come to see me, both with fixed appliances. So somebody with a lot of expertise was doing work for her. It may well be that she moved and the treatment wasn't completed, but she's certainly a long way from where she wants to be. She's very unhappy with the prominence of her upper incisors, the way her lips, lower lip catches underneath, and she's also conscious that her front teeth are not in the middle of her smile. She's got a big smile and it really shows. So she's missing a number of teeth. She's missing the 2, the 6 and the 7 on the left side, and in the lower she's missing lower right 6. She's only got 3 incisors. I don't know whether one was extracted or whether it was congenitally absent, and then lower left 5 is missing, and furthermore upper right 6 is failing. It's quite handy that the upper right 6 is failing, because I should just say, because her upper center line is over to her left, if we close this space, then we can help to correct her center line. And the plan is going to be to open the space where the lateral incisor is missing and close the space where the upper right 6 is failing. Originally, the expectation was to put implants in these lower spaces, but there is a real issue with narrowness of the ridges. She's very petite, and Dominic's concerned that there's going to need to be quite significant bone grafting to make implants successful here. So he asked me if I could close the spaces. Well, I might be able to close the spaces. I'm not worried about moving teeth into narrow areas of bone as long as it's along the line of the arch. But what I'm concerned about really is whether Karolina can really do it on her 3rd course of orthodontic treatment when we're already 18 months in, because it's going to mean wearing elastics between her upper and lower teeth for full time. But when I tell her that the potential is that she won't need 2 implants, she's surprisingly good at wearing elastics. And just to show how good she is at wearing elastics, here we are, we've closed those spaces. I've put temporary buccal fixed retainers because I'm worried about the spaces springing open. And here you can see the failing 6, and the idea is that that's going to go, the space will close, which we've achieved. We're opening a space where the lateral is missing, but with the elastics and space closure, we're getting a full unit change in the canine relationship. This does not happen overnight, and it's very unusual to see a class 2 canine relationship becoming class 1 when at the same time you're closing a unit of space in the lower. But these things are possible in a well-motivated patient, and it takes time. So here's her smile before treatment. This is just showing how we open the space and how we maintain aesthetics as we open a space. It's just a composite tooth bonded onto the central. And then stabilizing with fixed retainers and removable retainers. And at this point, she goes back to the team at Smile Concepts for her restorative work. Dominic's going to tell you more about this. But here she is with restorations on the lateral and a nice little bridge there replacing the lateral. So we need to remember when we're looking at symmetry that she's got 3 incisors, not 4. So we're going to have a single incisor in the middle of the smile. And here she is after her treatment, and really I think we've really achieved our objective here. It's not that everything's perfectly symmetrical, but really we have, I think, got as good a balance as we can with our class 1 relationships at the side and that lower incisor sitting in the middle. And we need to retain it, and we need to maintain the restorative work, and those things go hand in hand. As you've already seen, these cases, they don't just illustrate one point, they illustrate a number of different things. I've chosen Louise because not only does she show a really important contribution from restorative treatment, but also the significant changes that can take place in soft tissues when we make certain movements. She's had orthodontic treatment as a child. She's grown unfavorably since then. She's fairly class 3, and she's been told that she's a surgery case. That's what she's been offered at King's College in London. And she's come to me, having moved up to the Midlands, and asked if it's possible to have treatment without surgery. She's got a significant upper centerline discrepancy because she's missing her upper left lateral incisor, and there's a slight asymmetry of the mandible that produces a greater crossbite on the right than on the left, but most of her lower teeth are in crossbite, and there's no displacement forward. She's got some crowding in the lower arch and some spacing in the upper, and having gone through a consent process that limits her expectations, we've agreed that I'm going to camouflage her class 3. In other words, we're not going to change the skeletal relationship. We're going to just change the teeth within that expand the upper arch, contract the lower arch, and create symmetry by opening space for a lateral. So first premolars in the lower are being extracted, and space is being opened in the upper, just with a coil spring. The lower arch spaces are being closed on a round wire because I want the lower incisors to tip lingually. And just to cut what is a long story short, we get to the end of the orthodontics. We've got a positive overjet. Yes, I've proclined the upper incisors. Yes, I've uprighted the lower incisors. That's what I'd expect with an underlying skeletal 3 relationship. Here is the occlusion and detail before, and this is at the end of the orthodontics. She's still got a slight centerline discrepancy. She has a mandibular asymmetry. I can't reasonably correct that. And then she's had an implant and a beautiful restoration on the implant. And as soon as she's had the implant, I've made her a new fixed retainer. And she continues to wear removable retainers. She has a great smile, she's very happy, and it's interesting how non-surgical she looks. She's a little bit class 3, but there's a really big difference in how she looks, because here her lower lip is being pushed forward and her upper lip lacks some fullness, and just those changes, she's still class 3, but you just change the balance enough and you really take the smile and the look into a different category. So I'm delighted that we could do that without her having surgery. I'm finishing with Robert. Robert's a favourite of mine. I imagine he's a favourite of everybody here who's met him, because he's just an absolute, he's like the honey monster. He's a lovely giant of a man, used to play a lot of rugby, and he's got strong jaw muscles. He really has. So he's been grinding away on these teeth for all of his life, and being class 3, he's really created a significant amount of wear. So I get this referral from Dominic saying, can you create clearance for me to restore these teeth? I'm thinking, well, I have to go back to first principles here. Well, we're missing a lateral incisor, and that is kind of handy when you've got a class 3, because it gives you some scope for expanding the upper arch. But it's a bit of a chicken and egg problem, because I want to put brackets on the lower incisors so that I can close some space and upright the lower incisors. He's got an extraction, he's missing a tooth here, so we've got some space we could close. But I can't put brackets on his teeth because there isn't enough enamel there. So here we are. We want to close this lower arch space, as that's going to help us to upright the lower incisors, and we're going to open the space where the lateral is missing, but I can't get any brackets onto those lower incisors. So what I do, which is what I often do in a more severe class 3 patient, is disengage the occlusion with a good old-fashioned acrylic removable appliance. This is not easy to tolerate, but in a well-motivated patient and a well-informed patient, they understand that it's a critical part of the treatment, because I need Dominic to build up these lower incisors so that I can put some brackets on. And so while I'm starting to procline the upper incisors, Dominic's started to build up the lowers, and he's going to give you some more detail about how he did that. But essentially, I've got something I can put brackets on. They don't look like normal incisors, but it's enough to attach something to. And so here we are. I can start aligning the lower teeth and then beginning space closure, and at some point soon we'll be able to discard the removable appliance, and then that's the day that treatment gets and patients really feel like they're making progress. So here we are, a bit of detail, just opening space, and this is what I love. I write to Dominic and say, how am I doing? And he says, the upper right incisor space is more than satisfactory, as is the position of the teeth in the upper arch. The root alignment of the teeth adjacent to the anterior space is also satisfactory. Fantastic. But I wonder if it'd be possible for you to evenly space the lower central and lateral incisor with a minimum space of approximately 0.5 millimeter mesial and distal to these teeth. Well, the answer is I'll try, but it's quite fiddly. But I love it that he says just what he needs. That's what I want to know. I mean, I'll do my best. If I know what I've got to do, I'll try. It is very, very fiddly putting little pieces of coil spring where you think the space is right, and putting active coil where you need to make the space bigger. It's very fiddly. I love doing fiddly things, but I hate doing fiddly things under time pressure. So if I've got enough time, I can do it, and then it's actually fun. So here we are at the end of the orthodontics. He's not wearing his bite plane anymore. This is the clearance he's got as a result of the orthodontic treatment. So it's quite interesting to see how much vertical change there is, considering these lower incisors have been built up. The fixed retainer goes on. I'm not going to be able to hold these tiny little teeth just with a removable retainer, even if he wears it diligently. Well, I might, but do I want to take the chance? No, I'm always going to put a fixed retainer on and make a removable retainer. But what I really want is some great restorations to stabilize things, and that's what he gets. So there he starts with his class 3 worn occlusion. There he is after the orthodontics with some great big spaces to fill. And here are the heavy-duty, super tough restorations that Dominic's placed to try and stand up to the incredible grinding forces that Robert's going to carry on applying to them through his retainers, though. He's going to wear his retainers. And at the end of it, he couldn't show his teeth before when he was laughing. He's a man who likes to laugh. And he posted this wonderful testimonial on our website, very complimentary about Dominic and I. He's only been to one restorative dentist and one orthodontist, so quite know how he knows we're this good, I don't know. But what I love is at the end is, if you have to travel, it's well worth it. The downside, none, unless you think smiling too much into the rearview mirror on the way home is a hazard. So there's an elderly man who feels great having orthodontic and restorative treatment, and however difficult a journey it was for him, it was worth it for him. So I'm just going to say, I hope that you've seen how mixing and coordinating orthodontic and restorative treatment can produce better outcomes than could be achieved otherwise by single sort of discipline approaches. And I'd call it a symbiosis, because there's a real enhancement, I think, in what these patients get. And it's going to be different for every patient, so it's going to need a lot of thought. You can't just automatically make the same plan for everyone. And that's going to mean understanding what the restorative dentist needs and what they do and how things work, and them understanding how the orthodontics works, and especially how the retention works or doesn't. So it takes a lot of communication. It involves a lot of planning, and the patient has to have very clear consent and understand what they're taking on. But it's incredibly exciting to do these kind of cases, and as I say, I value being able to work with such a talented team here. So do contact me if you want to communicate about patients. I'm very happy to receive questions about patients I've never seen. I may not answer emails for a while because I get too many, but the ones I like to get are about patients, and so I'm very happy to receive an inquiry, because you might want to say, can I send you some photos? I don't know whether this patient could have orthodontic treatment. Very happy to receive those, because it's what makes my practicing life exciting. So thank you for your attention, and I'll pass you over to Dominic.
Does anybody have any questions for Peter, just while I'm setting my slides up? Are we all okay?
I didn't use my water.
Oh, yeah, that
In fact, I'll leave those for you and I'll get my own. Yeah?
How long will it take to intrude those two incisors in the blade? Like 20, 30 years?
The intrusion itself, in itself, is quite quick, but you have to. It's the rest of the treatment aligning the arches, building up to stiffer wires. Because we start with flexible wires, but we have to continue with rigid steel wires to make it work. So and then there are other things going on, which is things like overbite reduction, arch expansion. So it's always a reasonable question, and the answer is teeth will move at about 1 millimeter a month. So when we start to intrude teeth, we can intrude a millimeter a month vertically as well as moving things horizontally. But it's the other things that we have to do as a part of the case. I've never seen a case who had completely straight teeth but just needed 1 or 2 teeth intruding who ended up having orthodontic treatment. So patients are motivated. They generally won't see the course through it or take on that kind of treatment unless they also have another orthodontic problem. There are exceptions to that, but it works much better if they also don't like other things about their teeth. So it's a bit of a woolly answer, but not many months to actually get them intruded. Yeah. Anything else?
Okay, I'll get cracking.
Yeah.
Okay, thanks for that, Peter. What I'm going to do really, I think, for probably about 20-25 slides is look at kind of what the orthodontist can do for us as restorative dentists. Is that okay? So we'll kind of be back on home territory more, okay? And then depending on time, I've got 1 or 2 cases that I've done with Peter, which kind of highlight some of these restorative issues. So as we go through it, it's probably best if people hold questions till the end and just jot them down, because I'm going to kind of do a whistle-stop tour of what the orthodontist can do for us. So it always kind of crops up as many questions as it answers to some degree. But if you can hold them to the end, that's really handy, because I may answer some of them as we go along. I've had quite a lot of experience with working with various orthodontists over the years. Part of my consultant training was spending, I used to spend a day a week for a full year on the joint ortho, cleft lip and palate, implant restorative clinic. And then when I was a consultant in Peterborough, I was the kind of orthodontic liaison by the fact that I was the only consultant in Peterborough. And so basically you have to pick up the orthodontics pretty quick because you're the only one there to do it. So Peter's covered quite a lot of this, but really what are the basic things the orthodontist can do for us? All of these. Malocclusion correction is the big one, because restorative dentists, basically what we're going to do is stick porcelain, composite or acrylic into an occlusion. That's what we do. It's not difficult. Okay? You could even get oral surgeons trained to do what restorative dentists do. It's that easy. Okay? But if the occlusion's wrong, your restorative dentistry is potentially going to do what? It's going to fail prematurely, because everything is going to fail in the mouth eventually. Once you get into restorative dentistry, none of it lasts forever because it's all compromised. That's why they had it in the first place, yeah? They've lost tooth structure, they've lost bone, they've lost gum, whatever. But if you put it into a bad occlusion, it's going to fail more quickly, is the problem. So if you're going to do restorative dentistry on patients, be it crown, bridge, composite, dentures, veneers, whatever, you want to get the occlusion sorted before you do it, is the main thing. What are the bad occlusions? You don't want class 3s, particularly if you've got anterior restorations, because they're going to fail more rapidly. You don't want restricted envelopes, and I'll come on to that later, because restricted envelopes are a little bit more subtle. You don't want deep overbites, because with a deep overbite, you're just going to get more frictional force on your restorations, and they fail. So Peter's shown a class 3, with our BFG, our big friendly giant, We've seen the class 3, and we've seen the deep overbite and how those veneers, When the patient came to me, I think the veneers had been off 3 or 4 times within a year of being placed. That quick it fails. The other things which are a bit more subtle that the restorative dentist can do for us is canine guidance. Because in an ideal occlusion, we want our canines to be our separating ramps, so that when the patient goes from side to side, the canines separate out everything else, and then you're much more likely to get a harmonious occlusion. You're not going to get posterior interferences, you're not going to get anterior tooth wear or bone loss or things like this. Crossbite's bad news for restorative dentistry as well. Okay. Also, as Peter's shown with a couple of cases, is creating space as well, because one of the big things we've got going on now is this reduction in caries, but this big rise in tooth wear. And I can't treat all of this tooth wear alone. I can't create all this space myself. The more severe cases are going to need the orthodontist to do this. Okay. Just to say, there are in your packs, I think I've put all these articles that I refer to, I think are in your packs. And there's a really nice article that Peter did with a deep overbite case. That was in the BACD journal, wasn't it, I think? And we've copied that one, and that's in your packs as well. So a lot of these cases that you'll see, we've actually put the cases in the packs, so you can have a look at those when you go back to your practice. And occlusion's critical. Okay. Really, as a restorative dentist, I spend a lot of my career treating cases that have failed from elsewhere. So what really interests me is why things fail. And so with the dentistry I do, it's all about trying to make sure that you're not going to get early or premature failure. Because you can see, you know, the way we've gone with dentistry is everybody happy that we've kind of gone more green, amber, red. And we've gone much more towards kind of risk assessment. So you can see on the left, there are things that you can do that carry a degree of risk, yeah? So you can see on the left, we've got something that carries a degree of risk. You can see on the right, yeah, that there are just things that are so risky that they're stupid, okay? And where you're really going to get burnt is bad occlusions. That's what's really going to burn the restorative dentistry. That article's in your packs, which is one called Occlusal Confusion, so have a look at that. But in that article, what I said was that most patients function perfectly well with a less than ideal occlusion. Why do most patients function okay with a bad occlusion? Because a lot of them do. There's millions of patients out there with a bad occlusion, but they function okay with it. Why?
Because of the way of closure.
Yeah, it's what they do with the teeth. Because your teeth often only come together when you do what? Eat.
No parafunctions.
Yeah, so if you just use your teeth for eating, you'll often get away with stuff. Okay? But if you're a clencher, yeah, or a grinder, or you put acid in there, yeah, any of those things, then it all deteriorates very quickly. And some patients' occlusions are so bad that they just wear them down without any parafunction because they're so bad. So what it's all about with occlusion is diagnosis. So if you see any of those bad occlusions, yeah, always think twice before you start sticking composite or porcelain in there. Just take a step back and think, do I need to sort out the occlusion first? And be quite happy to say what to the patient as well, that we're not often very good at. Just say no. So I'm quite good at that. That's why a lot of patients go to see Peter. So just say, no, I'm not doing it. And they'll go, what? You won't? No, I won't do it. Why? Because you're going to be like him. Okay? I'm going to be one with a saw. I'm sawing the branch off. It's all going to fail. And then they're going to blame who? They're going to blame me. I'll do that, yeah? I'll do that because I spent all my life doing restorative dentistry, so I'm pretty good at getting across the tightrope, yeah? But I ain't going to do that, I'll tell you that, okay? So don't be afraid just to say no, and then the patient will do what? They either do it or they go somewhere else, but then it's not whose problem. It's not your problem. But if you do that, that's your problem. Okay? So just don't do that. Okay? And that ends up sometimes in an awkward conversation. Okay? But you're better off having the awkward conversation when? Yeah, before you've put porcelain in there, composite or some restorative material. Have the awkward conversation first, yeah. Okay, and Emma's not here at the moment, but Sam, you're pretty good at this. The door kind of opens, doesn't it? Sam's very good at the door opens, and everything's kind of saying to the patient, leave, okay? Because I'm not going to do what you're asking me to do, because it's just going to fail, okay? But occlusion-wise, that's what happens if you've got bad occlusions, yeah? And you put restorations in there. You can get tooth surface loss, tooth fracture, restoration fracture, restoration failure. You can even get bone loss, tooth mobility. And where do you end up? You end up with taking teeth out prematurely. But then, if you're really stupid, you replace them with what? Implants. But that's even worse because they don't have a periodontal ligament. And they don't have any proprioception. So things just get worse. Okay? So just be careful what you do in the first place. Okay? These are some of the more subtle things that the orthodontist can do for us, though. And that's what, that's what I'm kind of more interested in now. We can reduce tooth preparation, and we'll talk about that a little bit. Correct midlines. And Peter showed you some of the really nice work, which I think is great, was reducing gingival display. But reducing gingival display without having to resort to surgery. Because a lot of those cases, depending on where they go, they'll end up as bimax osteotomies to try and to correct the gingival display. We can improve symmetry, create golden proportions, and certainly what Peter showed that a lot of dentists aren't aware about, you can create bone for implants. And that's really useful, particularly in the mandible, where bone grafting is quite difficult and more prone to failure. And you've got nerves and things, and if you kind of poke the nerves or tear them, things don't go well. Okay. Tooth intrusion and extrusion, and something actually Peter didn't go through, because I'll cover that, is the perio patients. Because we see a lot of patients, and Peter's seen a lot of patients with Hank de Val as well, haven't you? Where, teeth, we've decided to keep teeth, but by actually working with the orthodontist, you can actually regenerate modest amounts of bone around teeth as well. And periodontal teeth can be moved as long as the periodontal condition is stable. Okay, so they can be moved. Okay. Don't forget, we can all be mini orthodontists quite easily. Dial appliance. Okay, because as orthodontists, all restorative dentists, are cheapskate orthodontists, because we can all do dial appliances. But you know what? You can't do much with a dial appliance, but you can do a bit with it. Don't forget the dial appliances for patients with localized anterior tooth wear. Not these, more complex malocclusions, and not the very deep overbites. But the very useful for patients like this are bulimic patients. Okay, so I see a lot of these. They're either bulimic, they've had something like really bad morning sickness, things like this. And these patients, you can create space very nicely with a dial appliance. Works in about 12 months maximum, creates the space, and then you can do your restorations after that. But that makes your restorative dentistry what? Predictable. Not just predictable, easy as well. It's just simple restorative dentistry, and it's predictable. That article on the dial appliance should be in your packs as well, so you can read up on that case. That should be in your packs. Okay. And this is the gummy smile case that Peter showed you earlier. But that's a brilliant slide. Peter kind of sectioned through the models. Yeah? Do you remember when did you get the lab to do that?
No, I did it when I had a model trimmer in my practice.
That's one of those are two of my favourite slides ever, those. But look at that. If you put veneers in that, they're going to do what? But somebody did it. Somebody put veneers on that, which means that they're what? Stupid. Okay? Okay? Don't be scared to say it. It's stupid. Okay? Admittedly, that they were probably one of the early members of the British Academy of Cosmetic Dentistry, probably, okay? But they put veneers on. Look, there's wear here, there's wear there. And if you ever see wear, you've got to look and think, what's causing it? And if you can't spot what's causing it, just take a step back and think, do you know what? I'm going to have a good long think about doing anything. But look, we get rid of the gummy smile. We give back the canine guidance. We get rid of the deep traumatic bite. I can't do that with a dial appliance. Okay? I can't do that with a dial appliance. I can put posterior onlays on, but that's quite invasive and it gets really expensive. So that's one of the good ways I sell the ortho, is it's cheaper than the restorative. So you hit them with a really expensive restorative treatment plan, and then I say, but you could go and see the orthodontist and it'll be half the price of that. And then they suddenly get very keen on orthodontics. Because before they're like, oh, no, I'm not paying that for orthodontics. I say, yeah, but you're going to be paying X amount per onlay. And for a few onlays, you could go and see the orthodontist, get everything in the right position, and then you can sleep easy for the rest of your life. Okay? And then I sleep easy because I know this isn't going to come back failing prematurely as well. Okay? And they look nice because it's Emax, yeah? And everybody sticks Emax on. Okay? I think that was about one of the first cases we did with Emax as well, because we did that case how long ago now? Yeah, yeah. So really old case, as you could tell from the lingual, because the lingual's gone a bit more sophisticated since then.
When did you start practice here?
I can't remember. I try and block it out. It's a bit like post-traumatic stress disorder, and you try and block it out. But it was a while ago. Yeah.
Because the referral was before you.
Yes. Oh, yeah. So basically, don't stick veneers on that. You could get away with that, though. Why? Because she could walk into your practice tomorrow and those veneers could have been there for 20 years because she doesn't parafunction. And she's a rat. She chews like that. She doesn't make horizontal movements. She chews very vertical. And she's a rat. And you could get lucky. But I'm not going to take the chance that I could get lucky. I would just say, no, go and have the ortho. Okay, but you will see those and you will see them work, because I've seen them work. But I'm not taking that chance. Okay. And that was the BFG. That was the big friendly giant. And he's as bad as it gets, because he is clenching like that. He kind of stomps into the surgery and sits down and immediately knocks over the... Does he do that in your surgery? Immediately knocks over the cup of water in the spittoon, immediately. Yeah, and then it takes us about 20 minutes to get him comfortable with towels and things everywhere before you can do any treatment. And that's just a corsicale. That's zirconia. Why is it zirconia? Because he needed a bridge, and I wanted to keep the preps minimal. So the zirconia let me keep the preps really minimal. Doesn't do well with bonded retention, though, does it? Because nothing sticks very well with it. And at the back of that, I even cut retention channels in it, didn't I? And it's still not very good. So that's one trouble with zirconia. I think you might find this more as an orthodontist, because a lot of people placing zirconia crowns now, But if you're going to try and do orthodontics and they've got a zirconia crown, you're going to have trouble with that. So if you see patients with zirconia crowns, you may have to take that crown off and put something like a lab-made acrylic on or a lab-made composite to get the ortho done. Because that just doesn't etch. Yeah, you can microabrade it, but it just kind of laughs at you. It's just not great for bonding to. So just think about that with zirconia.
So months ago, in Birmingham, I got in touch with Huntley. They gave me to try one adhesive, the last one, the latest. And I've tried it on zirconia, and really does bond.
Worry long term.
I don't know that. But
yeah, worry
I
long
tried
term.
In the lab.
Yeah.
We put composites, we put everything, we couldn't debond it.
Newer zirconias are better, but be careful with zirconia. The better it looks, the less dense it is, and the more likely it is to fracture. But even then, nothing bonds to it very well. It's not great. Okay? But he's happy to accept what is kind of compromised aesthetics, because they're not great. They're a bit okay. You know, I look at them and I don't look and go, well, that's nice, that's sexy. I just look and go, they're all right. It's a bit like metal ceramic. But it gives him the aesthetics that he's happy to accept, and it gives him his function back as well. Okay. Canine guidance as well. Sean, you'll know this one. Canine guidance. That's one of the most fundamental things with your occlusion. But look at this guy here. Lower right, complete crossbite. Lower left, the canine is just pushed out the way. He has no canine guidance. And if you do an occlusal examination, you spot trouble. Look at that. Where, there. And if you see anything like that, just stop and think, what's causing that? Okay. And the dentist who referred this in spotted it. Dom, could you see this patient? He came to see me, and this tooth here and this tooth here, which had small fillings in, literally virtually decoronated. He doesn't parafunction, he doesn't clench, he has no habits, but just a lack of canine guidance and a slightly compromised tooth, and he basically decoronated them. You stick crowns on those with a lack of canine guidance, and what's going to happen? Yeah, I don't know. Yeah, because I'm a restorative specialist, I can give you a long list of things that might happen. But certainly if you stick crowns on those, it's going to wear those more quickly. And some of those deep overbite cases Peter showed you, I've seen crowns stuck in those cases, and I've seen the lower incisors worn to gum level in a decade. 10 years and the lowers are at gum level that quickly. But you could put crowns on those and the compromised structure breaks. He could get bone loss, he could get mobility, he could get all sorts of things. So the one thing you tell him if he asks for crowns with that occlusion is what? Just say no. Okay? Can't do it. Yeah? Don't have a magic wand, I can't do everything. Got to get the occlusion right first of all. Okay? And you need to do that with wires and brackets. Okay? Probably. You couldn't. All of that with Invisalign? Yeah, I'd agree with that. But look what it makes my job, yeah? Okay? Because I'm not as bright as Peter, yeah? Because I'm the restorative dentist. I just do crowns and composite and acrylic. Makes my job easy. I do a wax up, yeah? The wax up controls the depth of my preparations. I do minimal Emax preps. I do my temporaries from that, and I make those as a template from that. The occlusion's right. And then my job is really what? It's easy. And I know that's going to do what, though, which is even better. going to last. Okay, that's the main thing. I put that on. He's got good caries control. His oral hygiene's good. Everybody sleeps easy because it's going to last. It's not going to fail prematurely. Okay, that's the beauty of having the ortho done first. Envelope of function. This is a little bit like a deep overbite case. But can everybody see there's wear on those lower incisors? Yeah? And can everybody see there's wear here? And there's wear there. And you look at it and it's quite mild wear, but it's a lack of room to chew. And she's got a slightly increased overbite. Can everybody see, and we'll look at it in a bit more detail, she's got very vertical upper incisors. So just looking at the teeth, don't worry too much about the skeletal relationship. But she has a slightly increased overbite, so she's lacking an overjet, and she has an increased overbite. And what she lacks is room to chew. And so when the teeth come together, they're hitting prematurely. She's wearing here, she's wearing there, and she's wearing there. So she just has a lack of room to chew. Okay? And she was referred to me because she's got wattle around those lower incisors. Bone loss. And she was referred to me as a perio case. And I was like, yeah, great, another perio case, hooray. Okay, really excited. Okay, I love perio. Okay, not as much as I love endo. And like perio case. And then I got my mirror out, started to have a little general look around and go, oh no, this is exciting. This is an occlusal case. So suddenly I'm interested. And she's got no bone loss anywhere else. But look. Those lower incisors, you can see the stepped occlusion now. You can see the wear. Everybody happy that how vertical those are. And so basically she's caused moderate wear, mild wear, bone loss. She's a clencher, and she had orofacial pain issues as well, didn't she? But after the ortho, yeah, we gave her a little bit more of a over jet, yeah, and we decreased the over bite. Well, I didn't, Sean did. Okay, and you can kind of see it here. Can everybody see that there's been very modest bone gain? Very modest bone gain. The teeth were slightly mobile. They're not mobile anymore because there's what? A bloody great wire bonding them together. Okay? Job done. She's not a perio case at all. That's occlusal trauma. Okay? And so it's much more exciting than doing root surface debridement. Okay? But watch out for occlusion because look, it causes wear, but if things are nasty, it causes bone loss. In severe cases, it can start to cause root resorption, and it can start to cause drifting of the teeth as well. Okay. And this is, I like this slide. This is the kind of Nanny McPhee slide. And, you know, it's a major aesthetic problem, that. Okay, major aesthetic problem. But look what Peter's managed to do for us. He wanted to keep the midline diastema, and interestingly enough, you can't see the retention wire. But with the orthodontics, managed to keep the tooth. This case is years old now, and I see this gentleman every year for a review, and it's completely stable. But look at what the orthodontics has done for us. Yes, we've had a little bit of root blunting, but we've had bone what? Bone gain. How much? From the original, look at that. you've got this interdental crater. Can you see that? You've got bone loss to here. Look at that. The bone comes back to here. So he's got no pocketing. The teeth are splintered. He's got good OH. He's got over 50% bone around that tooth, so it should last him for what? That should last him forever. If he sees the hygienist, that will last him forever. It's already lasted him about, what, 5 or 6 years? Completely stable. Okay. But certainly you've got to get the perio stable, yeah, before you do any of the orthodontics. And don't do it unless their oral hygiene is what? Yeah. Because it's going to get more difficult when Peter puts all his machinery on. It is, isn't it? It's going to get more difficult for them to do it. But if they're well motivated, they can do it easily. It's not an issue. Okay? And what else is he going to have? He's got such a bad occlusion. You put a resin bridge here, the resin bridge will be lucky to make it out the car park. Okay? So a resin bridge isn't going to work. An implant's not going to be great either because he's periosusceptible. He's got a bad occlusion. So there's no doubt trying to save the tooth is the best option. Okay. And then the other thing, because everybody's gone implant mad, is if you're going to do implants, work with a good orthodontist. Okay? Because I know if I'm doing an implant case with Peter, it's fine. I know the roots are out the way. Yeah? That's not one of Peter's cases, by the way. But that was sent back to me by an orthodontist going, that's ready for the restorative phase. I'm like, you serious? And look, from the picture there, it looks kind of what? Yeah, if you just have a quick eyeball, it looks kind of okay. If you look at it in more detail, you kind of think, oh no, that's a bit, and that's a bit, and the space is a bit narrow. But I can't put an implant in there. Okay? So just be careful if you're doing implant work that you're working with a good orthodontist. Because over the years I've had so many cases, particularly in the hospital and from various places, where you just can't get an implant there. It's going to take out half that root. It's going to take out half that root. Yeah, it's more of a lateral kind of lateral apicectomy. But don't forget, with your implants, you need the roots out the way, and you need at least 1.5 mm space either side. Okay? But I've worked with Peter so long now, Peter sends these patients back for me to check, and they're always ready to go. They're always done and ready to go. Okay? Because look, if they're well done, my job then becomes what? Easy. Okay? My job becomes easy. It's less stressful, it's more enjoyable. Yeah, if I want the stress, I can go home for that. Okay? I don't need to come to work for loads of stress as well. Okay? And then the crowns look nice because they're made out of what? Emax. So, look, all I did, I was just the monkey who put the implants in and then puts the impression copings on. You do an impression, the lab do the rest, so the lab know what they're doing. I just stick it all on, so it's easy. It's really easy because everybody else is doing the hard work. Okay? So everybody happy with that? Anybody got any questions about what the orthodontist can or can't do for us?
Can I just ask you about, obviously you're seeing these cases as a specialist. In general practice, when you're seeing patients who are maybe younger with wear, or starting to get some wear, but not to the point where it's causing them any problems or there's any restorative stuff to actually do, what would you suggest that you actually do? What point would you need to refer to somebody to say, right, do we need to do something about this or not?
Just monitor it first, because you don't know. Sometimes you don't know how quickly it's advancing. Because I've had people come to see me and they've knocked out, say, 30% of the tooth through wear. And you do a diet history is the first thing. Look for anything acidic, yeah? Then make them the kind of soft bite guard if you think they're clenching at night. And I've had patients with really bad wear who've been stable for, crikey, 10, 12, 13, 15 years. So don't always rush in to have to do something. You've got to rush in, though, if you think it's getting worse. Yeah? And then is the time to go in and think about doing something then. Then if you can actually see, that you can show them that it's getting worse, the motivation for them to have the treatment is more. Because if they can't see anything going wrong, it's difficult to motivate them. Do you see what I mean? Well, it just is. So monitor it, but when you think it's progressive, then get stuck in and do something then, I think, is the main thing to do. Is that all right? Okay, what time are we at? I'm going to show you one case very quickly, which is this, because it's all going on. Okay? And it's an ugly smile. Why is it ugly? Everything. She should have symmetry of the central incisors, yeah? She shouldn't have a black triangle. The laterals get worse because one's peg-shaped, the other one's missing. Okay. Actually, canines aren't bad. Let's put a positive spin on it. Okay. Midline's off. She's got wear on the lowers. She's got spacing. The smile's a bit gummy. But look, occlusally, she's got a really deep what? Overbite. And that's probably causing what? That's probably causing that wear there. It's causing that wear there, and it's causing that wear there. So if you leave it, it's only going to get what? It's only going to get worse. Okay? And so, the instant she walks in, it's ortho. As soon as she walks through the door and smiles, I think she's going down the road to see Peter. Okay? But I think at least I'll get a couple of implants out of it. Okay? But then I look at that and there's no what? There's no bone. Do you really want to be bone grafting there where just under there is what? Mental foramen? Probably not. So, and you can tell her it's going to be what for a couple of implants? You're not going to get a decent implant for less than about £2,000 per implant. So £2,000 for that, £2,000 for that, at least £1,000 for some bone grafting. That's at least £5,500 worth of treatment. That will go a long way to paying for your what? That'll go a long way to paying for your ortho, and you've got no spaces. So it's very easy to sell the ortho because, don't put your prices up, Peter, but the ortho is good value basically. Because you can close the spaces and you can sort the occlusion. I can't do that because I just kind of drill stuff. Okay. That's doomed. Okay. And then she's got this big space here, but she's got absolutely no what? She's got no bone. So she might be heading for an implant somewhere. Okay. But, look at her. She's doing really well. Oral hygiene's excellent, everything's coming along well. And then I have the occlusion I need. Look at the bottom. How much restorative work does she need at the bottom? None. And patients are much better off without what? They're better off without implants, yeah? We're all happy with that? You're much better off closing a gap than putting an implant in. Okay? At the top, we've got nice root alignment there, so it's quite easy to put in what there? Implant, but she's run out of money. Okay, so she runs out of money, so I just do her a little adhesive bridge. Okay, here with the peg-shaped lateral, we can actually either do that in composite or just put an Emax crown on it with virtually no prep. Because look, Peter's left me, there's a little bit of composite there with the spacing, so there's hardly any prep to do with that tooth. Peter's also tucked the teeth in a little bit, so I don't need to do any buccal tooth prep. So when you get to the final stages with these cases, you can ask the orthodontist if they can to do little subtle movements. So you can reduce buccal tooth prep or reduce tooth prep on the palatal, or just move things a little bit. So when the case comes back to you and the orthodontist says, what do you think, Dom? Just have a look at it and think, actually, what can I now do? Yeah? Because you don't want to be asking them that at the start of treatment, because there's so much to get moved. At the end, look at it and think, where would I want those teeth? Yeah? To maybe just change the occlusion a little bit. Yeah? Yeah? Or can I ask the orthodontist to move the teeth a little bit to minimize the tooth prep? Okay? And just explain, because that's not going to be the quickest job in the world for the orthodontist to do. It's going to take a few months. But just say to the patient, this is going to save your tooth structure. You're going to be left with a stronger tooth at the end of it. Okay? And then she has a little bit of dead cow bone in there, so she can have what? An implant. Okay? So, you know, she's got real issues there, but post-ortho, everything looks great. That's the prep for the EMAX, which is really minimal. That's still pretty much completely in what? It's enamel. It's a 360 veneer, it's not a crown prep. And then she gets a little zirconia adhesive bridge, only because if you noticed, her teeth are really translucent. So if you put a metal adhesive bridge on there, it's really going to grey that out. Okay? Is that going to last her forever? No. So she's been told to save up for what? So she's saving for the implant. So when that falls off, she can have the implant. Okay? And there we pop a little implant with a crown on the implant in the dead cow bone that she's got. Okay? So she's left with minimal restorative spaces. And so by doing the ortho, it actually just makes the whole thing cheaper for her. Less maintenance, because there's always less maintenance with your own teeth than crowns, bridges or implants, without a doubt. And then a little bit of reshaping, a little bit of composite, and the whole smile looks a lot nicer. Okay. But it should do what? Should last as well. And that kind of brings us back to the point we had at the start, is the orthodontics can do all these big things for us, yeah? But it can also do quite a lot of subtle things that sometimes we just kind of don't think about too much. Okay, I'm going to stop there. Any questions at all? Are we all okay? Because that's a bit of a whistle-stop tour. The lecture is going to be available, isn't it, Alan? Online? Yeah, from now, watch on Facebook. Nobody's going to want to watch it again now. Yeah. If you want to watch this again now, you need help, okay? But if you want to watch it tomorrow when you've recovered, have a look then. And a lot of those cases actually are in those packs. The articles are in the packs. There's a really good article by Peter on the deep overbite case and a few of my articles. So you can go back and read through those and also have a little look at the lectures as well. Okay, if you want to review that. So, we haven't, I don't think, organised any of the dates now for the study club, have we? Because this is the last of the year. So for the future study clubs, obviously we'll send you out the info, yeah, when we know when we're going to do next year's as well. Do make sure, or sign in because you didn't sign in. Do make sure that you sign in and your CPD certificates will be emailed out to you. But do make sure you've been signed in or it won't get emailed out to you. Is that okay?
Any more about courses, dehti.co.uk?
Oh yes, if anybody wants to find out more about the courses, yeah, it's the Dominic Hassall Training Institute.
dehti.co.uk.
dehti.co.uk.
Video about Facebook as well.
Yeah. And if you come and do the course, the second year is good because you get a morning with Peter. on adult ortho, so he gets more time to. The rest of the course is rubbish, but the bit with the day with Pete is really good. Okay. Any questions at all? Are we all okay? If anybody thinks about anything, yeah, they can just email in questions, because it's quite a lot to go through in a quick session. But hopefully it'll keep you out of trouble. Okay. Thank you very much. And what we'll do is the details for next year's study clubs we'll send out when it'll be kind of in the new year, because I'm going to be sorting out the dates kind of tomorrow for that, and we'll finish there. Okay. No worries. I'll see you all soon.